Good day, everyone. Assalamualaikum. Sawadika. I am Dr. Eliera Sufarna. I am a lecturer of Orthodontic Specialist Study Program from Universitas Sumatera Utara, USU. In this occasion, Faculty of Dentistry USU are co-joining Prince of Sompai University for community service at PSU Dental Hospital on October 2025. In this video, we are going to talk about oral bad habit, its mechanism to malocclusion, how to intervene and prevent the bad habit by demonstrating particular oral exercises as myofunctional therapy to help overcome the problem becoming worse. Please enjoy our video.
So, what is an oral bad habit? Oral bad habits, often called parafunctional habits, are defined as repetitive behaviors involving the oral and perioral structures that, if they persist beyond an appropriate developmental age, around 3 to 6 years, exert continuous and abnormal forces on the teeth, jawbones, and surrounding soft tissues. These habits are often considered environmental factors that disrupt the delicate muscular and skeletal balance essential for normal craniofacial growth and development. This disruption can often lead to malocclusion. In this video, we are gonna talk about 4 major oral bad habits that can cause malocclusion, such as mouth breathing, tongue thrusting, thumb sucking, and lip sucking. The first oral bad habit is mouth breathing. Mouth breathing is a condition or habit in which a person breathes primarily through the mouth instead of the nose, either during rest, speech, or sleep. Normal breathing means air passes through the nose for inspiration and expiration during rest, speech, and sleep. Abnormal breathing is when air passes through the mouth instead of the nose for a prolonged period of time. A prolonged mouth breathing habit may adversely affect the development of the teeth, facial morphology, and the lips. Mouth breathing habit can affect the teeth, the occlusion, the face, and the lips. Examples on the effect of mouth breathing on the teeth include constriction of the upper jaw, spacing between teeth, and marginal gingivitis. Examples on the effect on occlusion include anterior open bite, protrusion of the anterior tooth, and posterior crossbite. Examples on the effect on the face include long face, lip apart posture, gummy smile, adenoid face, and adenoid hypertrophy. The last one is the effect on the lips, include incompetent lip, short upper lip, and everted lower lip. Here are some exercises that you can do to intervene with the mouth breathing.
Step 1. Sit up straight with your mouth closed and your jaw relaxed. Inhale through your nose. Step 2. Relax your body, focus on your breathing. Step 3. Press your finger or knuckle on one nostril and breathe out gently through the other nostril. This step allows you to determine which nostril tends to be more or less congested. Step 4. After determining which the less congested nostril is, press your finger or knuckle on the less congested nostril and breathe through the more congested nostril.
The patient is asked to sit in a relaxed position and instructed to close their mouth and focus on their breathing slowly and calmly for 1 to 2 minutes. This aims to increase awareness of nasal breathing as the primary breathing pattern. This exercise is performed by exhaling through the nose, then hold the breath for 3 to 5 seconds before inhaling again. This method helps to slow down the breathing rhythm and reduce the dominance of mouth breathing.
Mouth breathing patient is instructed to close the mouth by placing a card between the lip. Perform nasal breathing through the nose while maintaining the position of the card for 3 to 5 seconds. Remove the card and the patient should be able to continue nasal breathing without opening the mouth.
Next one is tongue thrusting. Tongue thrusting is a dysfunctional pattern of tongue position and movement where the tongue pushes forward or sideways during swallowing, speaking, or even at rest, causing the tongue to press to the anterior teeth or the interdental space. Common clinical features found in patients with tongue thrusting are edge-to-edge bite, anterior protrusion, and anterior spacing. The correct tongue resting position involves the tip of the tongue resting on the anterior palate behind the upper incisors, the dorsum of the tongue gently resting against the palate, the lips closed and relaxed, and breathing occurring through the nose. As we can see in these pictures, the correct tongue position is the one on the left. The one on the right is incorrect. The management of tongue thrusting include orthodontic appliance like tongue clip or palatal clip to prevent the tongue from pushing against the tooth, tongue exercise, correction of medical causes like adenoidectomy or tonsillectomy if the cause is obstructive, or multidisciplinary collaboration including orthodontist, speech therapist, and ENT. Here are some of tongue exercises you can do if you have a tongue thrusting habit.
The first one, tongue click, which aims to strengthen the tongue muscles. The child should look in the mirror to see the correct tongue position on the palate just before clicking the tongue. This activity will stimulate the child to achieve the correct tongue resting position with the entire tongue. Continue this until the child can comfortably rest their tongue on the palate without tension for at least 60 seconds. The exercise is considered successful when the child can produce a stable volume click sound 60 times. The second one is tongue spot. The child is asked to find the spot on the roof of the mouth behind the upper incisors. Hold the tongue in place for 10 seconds and repeat it 10 times. The third one is 4S tongue exercise. 4S stands for spot, salivate, squeeze, and swallow. Place the tip of the tongue on the spot just behind the upper incisors. Gather saliva in the mouth. Press the tongue firmly against the palate, starting from the front and move towards the back, and swallow the saliva while keeping the lips closed and relaxed. It is recommended to perform this swallowing exercise at least 40 times a day. The fourth one is tongue pull exercise. Slowly pull the tongue out and hold it with your hand while applying light pressure. The variation is pull the tongue up, down, left, and right. Chew a piece of gum to soft consistency and roll it up on the back of the tongue. Place the gum to the palate with the tongue. Spread the gum thin on the palate with the tongue. Swallow saliva while keeping the gum with the tongue pressed to the palate, so that the gum spread along the palate after swallowing. Chew the gum hard through all of the steps. The last one is monkey face exercise. Ask the child to place the tip of their tongue on the front teeth under the upper lip, with their tongue tip covering the front teeth. Hold for 10 seconds and repeat it 10 times every day. This exercise is fun and strengthens the muscles.
Now, let's go to thumb sucking. Thumb sucking is an oral habit characterized by sucking the thumb, which is commonly observed in children. This habit is considered normal at an early age, under 3 to 4 years, as part of the oral phase of psychosexual development. However, if it persists after the eruption of the permanent teeth, it may lead to malocclusion and disturbances in dentofacial development. The impact of thumb sucking depends on its duration, frequency, intensity, and the position of the finger during the sucking. Common orthodontic clinical features include anterior open bite, where the anterior teeth do not make contact during occlusion, protrusion of maxillary incisors and reticulation of mandibular incisors, where the upper front teeth tend to be pushed forward. The lower front teeth are pushed inward. An increased overjet can also be seen, where the horizontal distance between the upper and the lower incisors become larger. An unilateral posterior crossbite and high arch palate are also commonly seen in patients having this oral bad habit. The approach to stopping thumb sucking can be divided into behavioral therapy and oral appliance therapy. In behavioral therapy, we can do positive reinforcements, like giving rewards when the child does not suck their thumb, or reminder therapy, using bandages, gloves, or bitter nail solutions on the finger. In the oral appliance therapy, the use of orthodontic appliances such as a palatal crib, rakes, or a blue glass appliance if the habit persists. Another thing to note that changes in tooth position caused by thumb sucking do not require orthodontic treatment if the habit has completely stopped before the age of 5. The malposition of the teeth will spontaneously correct itself without orthodontic intervention. Now, let's go to the last one, lip sucking. Lip sucking is a repetitive habit where a child pulls their lower lip into their mouth, often unconsciously. It usually starts in early childhood and can continue for years if not corrected. When a child sucks on their lip constantly, it applies unnatural pressure to the front of their teeth. Lip sucking exerts direct force on the teeth or the tissues that support them. The habit of lip sucking can cause a wrinkled or golf ball effect in the area of the symphysis, as you can see in the picture. Other features include incompetent lips, labial protrusion of the maxillary incisors, and a lingual displacement of the lower incisors. The duration, frequency, and intensity of the lip sucking habit can impact its level of severity. The treatment of lip sucking involves physical interventions such as lip balms for chapped lips or dental appliances like lip bumper for persistent habits.
That's all from our video. Hope you guys enjoy it. Thank you for watching. Assalamualaikum. Kapun ka.